Good evening, everybody. Welcome to this session. We will begin in 1 minute or so. In the meantime, can I just have some messages in the chat area, please, just to confirm that you can all see and hear us. Fantastic. Thanks, everybody. We'll begin the session at 2 minutes past, just in case there's any latecomers. Thank you. We'll be with you in 1 minute. Okay, then we'll make a start and anybody can join us later on. Welcome, everybody. Thank you for joining us for this Mind the Bleep session on preparation for core training interviews. My name is Glen. I'm a member of the Mind the Bleep team, and we are very lucky to be joined this evening by Dr. Dan Furmedge, who is a consultant in internal medicine at Guy's and St Thomas's in London. He has a special interest in undergraduate and postgraduate education. He is a training program director for IMT and is also an MRCP examiner. In a moment, he'll talk for 40 minutes or so about tips and tricks for preparing for your core training interviews with a focus on medical core training, IMT. After which we'll spend 1/4 hour or so having a bit of a Q&A. Please feel free at that point to ask any questions using the chat function you can see here on the right of your screen. You are welcome to ask questions during the presentation as well. I will make a note of them and we can answer them at the end, but just bear in mind that we may well answer some of those questions during the course of the presentation. So that's enough of me talking. I will now hand over to Dr. Furmedge. Thank you very much.
Thank you very much. Hopefully you can see that. So thanks a lot. I can see a few names of people I recognise on here. So they've asked me to come and talk to you a bit about how to do your interview well. I think there are some generic messages that will be applicable to anyone who's doing any core training, but the focus is going to be on internal medicine. But I think a lot of the other surgical ACCS interviews, they have similar sections. So hopefully there'll be some transferable messages. I'm going to spend all day next Wednesday doing IMT interviews, and I've done quite a few over the years. And I think reflections, it's not until you've seen probably 100 people interviewing that you start to notice the patterns in what people do well and what people do really not so well. I'm hopefully just going to give you some tips. It's difficult to teach interview skills from a lecture, but hopefully there'll be some stuff. So in terms of the IMT interview, hopefully if anyone's interviewing in the next couple of weeks, you'll know this already. And I would say if you're doing something else, you need to look very carefully at what interview you're doing and how you're going to structure it. But first 6 minutes, we will sit there and read your portfolio. The old days were better because you came in person and you brought us your portfolio, and often people would put all sorts of great things in there, like a photo of them at the top of a mountain or a photo of them on the top of a horse, which we used to enjoy, but we don't get that anymore. But we will be looking through your portfolio, so you can expect us to know what evidence you've supplied, and we may ask you about that. And we'll be looking for, have you got stuff relevant to medicine? What's the quality of the stuff you've got in there? And have you kind of roughly scored yourself correctly? And if you haven't, we will ask you in the interview to justify why you've given yourself a certain score potentially. Then you'll move on to the bit about why do you want to do IMT? What have you done? And that now is a 2-minute presentation, which allows you to summarize what you have done and why you want to do IMT. Then we'll talk to you a bit more about that and probe you a bit more to check that you actually do want to do IMT, because we're very aware that a large number of people applying are doing it as a backup specialty, are doing it because they are probably going to go and do something else, but they just want to see what they're doing, or many people are doing it as a practice. Obviously, we can't stop you from doing that, but this year, particularly with the high numbers of people that have applied, it means that lots of people who really do want to do IMT haven't been offered an interview. So we'll be really looking for the people who really want to do IMT. There'll be a clinical scenario, which you'll get 3 minutes to read a short vignette in the interview, and then we'll talk to you, and then the ethical and professional scenario. And then we give you a global communication mark. So I'm going to go through some of that and tell you sort of what I find people do well and what they don't. So in IMT, we score you 1 to 5. Surgical interviews are 1 to 6. But generally, there's a similar scale. So the level we're looking for to get a score of 3 is somebody who is exactly as you would expect it to be applying for IMT, level of mid FY2. It's very difficult, obviously, to judge what that is for someone at that level. It takes us some years to work out kind of what an average mid-level FY2 would know. The knowledge level, I would say, is not as high as you might think it is. A 4 is someone who you'd expect to have a bit more experience and is working at the end of FY2, and a 5 is somebody who is working, within the IMT level already and really is able to talk to us more about the advanced aspects. If you say something unsafe, or you compromise patient safety or dignity, or you say something that really demonstrates that you don't have the basic knowledge that we would consider safe, you'll get a 1. Or if you just really aren't interested. So the one that amused me was when I was doing geriatric medicine interviews, some guy turned up and the ethical scenario was about a safeguarding social issue, and he just said, "Well, it's a social issue, it's got nothing to do with me." And despite prompting him, he really couldn't even think that any of that was relevant to him as a future geriatrician. So that's the sort of thing that will get you a 1 or 2. Superficial answers, missing key parts of management. And in terms of what you need to do to demonstrate your skills in IMT, again, there's some guidance on the website, but it's all about, have you done a reasonable level of stuff to show that you're committed to IMT training, and have you done things that show kind of achievements across the domains of research, teaching and education, leadership, quality improvement. We're not looking for, mega projects. 2 or 3 achievements that demonstrate your kind of interest is fine, but be prepared to talk about those things. Obviously, there's loads of amazing people around who've spent their entire weekends and evenings doing nothing else but doing projects to kind of put in applications, and some people are never going to be able to live up to those people, but it's perfectly easy to score same as those people by talking about your achievements in a sensible way. So what should you do between now and your interview? So make sure you know the structure of whatever interview you're going to. So as I've just mentioned, look at what the timings are, feel comfortable with that and practice doing it, and know where to pitch your answers in terms of scoring. You need to know your portfolio and what you've put in there, because as I say, we go through it. We've got 6 minutes to look through the evidence, and we will be looking for things to pick out and ask you about, and whether that's asking you to explain more about your QI project or your leadership role or your educational aspect, or something that you've written about, something of interest that you do outside of medicine. You need to be able to talk about it. You need to be able to defend why you've given it a score. If you've hedged your bets and you've sort of gone for the score above, you should be able to explain why you thought that was the case. And you should be able to talk enthusiastically about it and in detail. So if you talk to us about your QI project and we ask you, what did you do? How was it sustainable? And you said, well, we put up a poster and then we reordered it once and then I forgot about it. That's what pretty much everyone does. So you need to give us something that allows us to know that you've demonstrated interest in QI, that you know that about how to keep QI sustainable, and those kind of things are important. The thing that really catches people out every year is people turn up having not looked at the IMT curriculum. All of it's available on the JRC PTB website, and I'll guarantee you there'll be a question about what is it about the IMT program you're looking forward to? Can you tell us what the key outcomes are of the IMT program? What things are included in the IMT program that set it aside from other training programs? What part of the IMT curriculum would you find difficult? because we want to know that if you're applying for a training program in internal medicine, that you understand what you're about to let yourself in for 2 or 3 years. So you should understand that that there are 2 or 3 years that what group 1 and group 2 specialties are. You should know that there is geriatrics and ICU, outpatients, and acute medical take are all mandated parts. Simulation forms part of it. You should have an idea of how the curriculum is run in terms of the generic and the clinical competencies and what the procedures are you'll be expected to get. Because it's very, very obvious when people have applied and come to the interview and they have no idea what they're actually signing themselves up for. And those are usually the people who aren't applying for IMT for the right reasons. You need to know the principles of good medical practice and kind of escalation. You don't need to know them in detail, but you should know the principles around professionalism and that kind of thing. So have a glance at those if you haven't done it recently. And then I'll talk to you more about the common clinical scenarios and ethical scenarios. So the thing you need to do, you never know how you're going to talk until you turn up and talk. So really practice with people, with your friends, just so that you can do the first run. Even if you just do one mock interview with another person who's applying for IMT, or your registrar or your consultant will do it for you, because the first time never comes out the way that you think it's going to in terms of structure and content, and it will give you some insight. And if you've done it once, hopefully the second or third time allows you to do it. Think about the wider aspects. So if you get an acute scenario, everyone's going to go and do a basic ABCD assessment and tell us what they think the investigations and management plan are. Some people will do that to a very basic, superficial level, and other people will give us an advanced, PACES style summary of the scenario. If you want to get a 5, then you need to be doing the latter. So you need to be doing the basics with your eyes closed. So I don't even have to think. If you turn up and there's a COPD scenario and it's somebody who's at high risk of type 2 respiratory failure, and I'm having to ask you, is there anything else you would do, trying to get you to say you might think about doing an ABG, you're not going to be getting a 4 or a 5. So if you can do the basics well, then what you need to be able to do is to signpost us the additional knowledge and things, and I'll talk a bit more about that in a sec. Lots of this is very predictable. The same questions come up every single year, similar scenarios. They're all reviewed every single year, but often they're very much similar to the ones from previous years. There's always a few new questions. So practice the kind of common things. There's lots of websites which tell you what kind of things come up in IMT interviews, and you can just practice answering those with your friends. And think about doing your driving test. So it's not just about doing the basics safely. For this, that will get you an average score if you want to score well, and we all know that the difference between a 4 and a 5 can put you in or out of London. For example, just think, how can I really demonstrate succinctly that I know exactly what I'm doing here, I'm safe, but I'm also thinking at the next level of someone who wants to do medicine and be a medic in the future. What comes across really well, people being enthusiastic, people being really succinct about what they're saying and structured. People, as I said, signposting without me having to ask you, can you think of anything else that we could do here, or are there any relevant guidelines that you know about? So tell us that without us asking, and that is always a surefire way of letting us know that you know what you're doing. As I say, waffling is one of the worst things that people do, keeping it unstructured and unsystematic, going, oh, well, yes, I do some bloods, full blood count, maybe a CRP, and I do a CT scan of the chest. You need to start from the basics and work your way through. And again, as I mentioned, but actually overall what we need you to do, and I cannot stress this enough, is just come across and appear like you're a nice human being who can communicate with other humans, who is kind, sensible, has common sense, can think on your feet, and is somebody that I would want to have on my team and go for a coffee with after the ward round. That will be more important than any of those other things. You can have amazing achievements and come across like a horrible twat in the interview, and people will mark you accordingly. So it really is important that you just try and come across as a normal human that you would want to work with and other people would want to have on their team. And if you do that, and then you do all the other stuff in a systematic, structured way, people will score you well. So a lot of these are just opposites. So as I say, we will try and weed out the people who really don't want to do IMT and are just doing it as a backup plan. We do that by making sure you know what the IMT program is. If you come across like you really have no interest in medicine at all, then that will be very obvious. That's also important if you want to be a super specialist, I don't know, neurologist who only does myopathy at Queen Square. You've got to get through a whole program of internal medicine training, whether you want to do that as a consultant or not. And with the shape of training and the people that turn up, the consultants that come and interview for IMT don't tend to be the super specialist myopathy neurologists. They tend to be the people doing general medicine and who have an interest in internal medicine training. So you've got to come and at least, even if you really can't bear the thought of doing IMT just to get to where you need to go, you've got to persuade us that you have an interest in medicine. Again, you really need to practice being able to think on your feet systematically. So again, just practicing giving us the standard rote answers without being able to adapt those to the clinical consultation or the question. So I'll try and give you some examples of that later. Not having any initiative. And again, the more we have to prompt you and guide you and get you through, the less well we'll be able to score you. You've got to give it to us. It's fine, if there's something that we want to clarify or you've missed something and we ask you and you come to the conclusion. We all understand that it's an interview and people are nervous and obvious things drop out of your mind and people can't think of the right word and people say, I know what you're talking about. Those kind of things are absolutely fine. If everything else has come across reasonably well. But if we're really trying to drag out of you, what's the differential diagnosis for breathlessness, and you can only come up with PE and pneumonia, and we're saying, is there anything else that could be, that's the kind of thing that's gonna be difficult. So if you come off as arrogant, even if you've got a great portfolio, if it comes across like you know it all, that's going to come across. If you're unsafe or don't know the basics, if you seem uncaring, uninterested, or unsystematic. So talking about the kind of bits of the interview, so the presentation, this is your opportunity to really showcase, number one, why you want to do IMT training. So that can be anything, but I would generally start with a statement as to what is your interest in IMT. So is it that you love internal medicine training and you want to be an internal medicine trainee because you find clinical dilemmas fascinating? Or is it that you want to be a neurologist, but you understand the importance of medicine and want to make sure you're a really good internal medicine physician before becoming an oncologist so that you can, deliver generalized care? And if you look at the recent things that have happened with the neurology, palliative care and cardiology, all these mandated to do IMT as a CCT now, there really is a push for everyone to be general. And you'll all have seen people who, you'll have worked for specialists who can't manage simple things and are calling other specialties to manage what is very basic medicine. So we want people who want to be generalists, and the whole purpose of the program is that you're going to be a generalist and be able to bring generalist skills with you. And that's why we include ICU. That's why we include so much medical take. That's why we include so much geriatrics, because we want the oncologists and the hematologists and the cardiologists of the future to be able to do the basics. So then think about something clinical that you've done. If you've done an F3 in medical specialties, raise that. If you've done an F2 in a medical specialty and you particularly enjoyed it, and then you've gone on and done a taster week in respiratory medicine, mention that. Commitment to specialty. And then if you've got any achievements in these domains, what we don't want you to do is list off, I've got 17 publications. The first one was this, the second one was that. Highlight, I've got 3 publications. I'm really proud of them. The one I'm most proud of is I did an original research project looking at X, Y, and Z. Pick either the one that's really relevant to medicine, or pick the one where you think you've done a really good job and you're proud of it. Similarly for QI and audit, I've been involved in a number of audit projects. The one I'm most proud of is the one I did about this, because of this and the change was embedded and I presented it at a regional meeting. I've led a local teaching program and I've done an education FY3 doing simulation. So pick a key thing, highlight if you've got multiple achievements within a domain, but we don't want to know about, just one or the other. And then, if you've got time, summarize, and you can practice this. You will be stopped at 2 minutes. There's not time to let you waffle on. So if you're still on your clinical achievements and haven't got anywhere else, we will stop you. And we may pick up on one of the things that you've mentioned and ask you about it. Or we may find something else in your portfolio and ask you to talk about that, as I mentioned before. So then we get 6 minutes to ask you about why you want to do IMT and why we should give you an IMT job. So again, we're going to ask you about things we've seen in your portfolio or things that you've highlighted. And if you're clever, you're going to tell us about the things in your statement that you want us to ask you about. So we'll go, oh, you mentioned that really interesting QI project that you did about delirium. Can you tell us more about that? And that will, then we may ask you, how do you know that was a sustainable change? What are the core parts of, QI and audit? So you need to be able to talk around those things, but talk enthusiastically and knowledgeably about what you have done. We would expect you to do that. And, it's perfectly reasonable to have stuff that is related to other specialties. If for your medical school career, you wanted to do obs and gynae and everything's directed at that, and then suddenly you've had a real change of heart because you did lots of medical jobs in your foundation program and changed your mind, that's absolutely fine, as long as you can explain and justify and persuade us that that's why you've done, and talk to us about the transferability of the things that you have done, and hopefully have done something towards medicine. You can talk. We might ask you about your clinical experience, what you've done, how you found it. We, as I mentioned, are going to ask you something to test that what you're actually applying for. So really do have a look on the JRC PTV website and have an idea of what you're actually going to do. Acute medical take, Jerry's, ICU, simulation, procedures, end of life care, discharge planning, acute presentations, outpatient clinics, and then all the usual generic stuff. We might ask you what you want to do. And again, it's fine to want to be a generalist or a specialist. We understand that everyone has to get through IMT, but if you're going to do that, at least tell us that you're interested in the whole shebang, because you've got to get through everything. And then we might ask you things like, what are some challenges of working in medicine at the moment? Can you reflect on what you've really enjoyed? Where do you see, what opportunities do you see in internal medicine? And there's an opportunity for you to reflect on something personal to you that you've done, or something more systems-based, like the role of generalism. If you want to be controversial and talk about something topical, things like MAPS and PAs, and how, obviously, again, you're not going to want to turn up to an IMT interview and be somebody who says you don't believe at all in MAPS and PAs, because I suspect that most of the people interviewing will be in some way supportive of the principle of expanding the workforce. But also recognise the challenges. So be prepared to sort of be asked something like that. You may or may not be. And this bit should be the easy bit, because this is asking you about what you've done, what you like, what your passion is. And it's a chance for you to get across your personality, your interest. And if there's a patient scenario that you have used or something you can pull, kind of vignettes and personal reflections come across really well. In interview, if you can bring something that, some personal patient anecdotes, those things are really important. So clinical scenario. So most likely you're going to get an acute clinical scenario that presents on the acute medical take, a top 20 IMT presentation. So you're going to get chest pain, shortness of breath, something similar to what I've written here. Of course, we can ask you really, and it would be reasonable to ask you anything that is in the IMT curriculum to see. Again, we wouldn't expect you to be able to do it to an IMT level, but we would expect you to do it to the level of an FY2 working on the medical take or in ED, and be able to do the basics safely and know where to ask for help. So you should sort of have a vague idea of these kind of areas. To get the sort of standard score of 3, we basically need you to take us through the ABCDE assessment, covering all the relevant aspects. So like I said earlier, if you've got someone with delirium who's not on oxygen, you don't need to do an ABG. But if you've got somebody who is on oxygen and has got COPD, you might be thinking about whether they need an ABG, for example. So it also has to be a little bit individualized. So when I said don't be too protocolized, obviously the ABCDE is protocolized, but it's worth thinking about what parts are particularly relevant to this scenario and really pulling them out for the interviewers so that you do it seamlessly. So by the end of your ABCDE, we know that you've really focused on being systematic, but have also picked out what's relevant to these particular scenarios. We need to know that you're able to do the basic investigations, interpret them, and then deal with the emergency management and seek help and escalate as appropriate. And then if you've done the basics okay, and we ask you some additional questions, if you've got some extra knowledge that you can give us, then that's probably fine, and we'd be happy with that. But that's what you need to do to kind of give us the basics. You've got to be succinct and seamless. Don't miss anything key. And if you do, we'll probably try and get it out of you to see if you know it. But, there are some key things that you really would need to know, the standard stuff. Again, tell us the additional bits that you're thinking about. I'll talk to you about this in a second as well. But really, it's all about giving us the basics and then showing us you're anticipating and thinking ahead to what's happening next. And you might highlight your own experience potentially if there's a particular case that is of relevance where you could think. And again, it's about if something slightly different happens, can you manage that? Can you think on your feet if something happens? And be prepared in some of the scenarios, not all of them. You may be given some very basic investigation results to interpret, like a very simple blood test result or an ABG result. You may be given additional information about how the clinical scenario has changed. And in some cases, you may say we may say something like your investigations confirm a diagnosis of pneumonia on the X-ray. So now tell us about the other stuff. So be prepared that you might need to interpret information as you go along. We don't give lots of information because we know it's difficult to do, but short snippets of information we would expect you to be able to manage. So just taking you through, I mentioned A, B, C, D, E already. So what we want the basic people to do who are going to get threes are give us the core, in terms of once you've done the A, B, C, D, E, you might be asked about history taking, or that might form a core aspect of the scenario. So we're going to need to know the core aspects of the history, any significant red flags or risk factors that are associated. So if you've got a PE, you've got to think about what the risk factors might be, and any kind of associated conditions that might be relevant. And if you can do the basics of that well, then you're winning. If you list off all the red flags and you tell us all the risk factors, and you can think about any associated conditions that might be related, then you're gonna score highly. Again, investigation is about being systematic and thorough. So you'll have done some of it in your A, B, C, D, E, but then you might move on to advanced stuff. So think about what do you do at the bedside: physical examination, bedside observations, urine tests, ECGs, lying and standing blood pressures, ABGs, blood tests. And again, like people do in PACEs, we don't want to hear, I'm going to do a full blood count looking for anemia and infection. I'm going to do a renal function looking for AKI. List off the blood tests you want to do. And is there any really key things in there that you want to pick out? If you're going to do, get onto the real stuff that you're going to do. The patient's confused. I need to make sure that I've done some bloods. There needs to be a calcium in there. Those kind of things. Then think about what's the basic imaging, what advanced imaging, microbiology, blood cultures, things like that. And then any other special tests that might be important. And that's usually when you're getting onto the advanced. What we'd expect from someone getting a 3 is to be able to do the basic bedside stuff, the bloods and any sort of basic imaging, and then be able to go from there with more senior support. Again, management, if you've got an asthma scenario, if you do nebs, antibiotics and steroids, and you sort of say, then I'll keep an eye on the patient, etc., and the patient's deteriorating. And actually, what we need people to then talk about is, do they know about magnesium? Do they know about, more advanced management of asthma with, theophylline and all the things that we don't do very often, but you would have an awareness of. Do you know how to grade asthma severity based on the guidelines? Would anything change how we adapt people? So, for example, you've got a PE scenario, but someone's got renal impairment. Can you tell us that that we need to think more carefully about the anticoagulation? So those are the more advanced things that we would want people to do. Always thinking about escalation planning. Most of the scenarios will be people who would be for full escalation. So it's about identifying when we should escalate to critical care and what we would be escalating them for, vasopressors, NIV, renal replacement therapy, intubation, high flow oxygen, what is it that we would want the critical care team to do, or if they've got frailty in the background, thinking about whether full escalation is appropriate. So the escalation side is more about early identification and escalation, and thinking of escalation planning when appropriate. There might be something in the scenario or questions around what would you do, if the patient's pregnant? Is there something around driving, renal impairment I mentioned? How are you going to manage them after the initial plan? Do you know about ambulatory care? Do you know when we can safely discharge people? Can you think about hospital at home? This is less likely to be so relevant, but if you're doing really well and you can start to talk to us about some of these things once the acute scenario has been managed, then you're going to look impressive because you're thinking about the next few days. If you can signpost relevant guidelines that you know of, that's really important because we know that you know where to look to help you if you don't know the detail. And again, if you've done the asthma management, the acute scenario, the patient's all sorted out, and you then start telling us more about the long-term management of asthma, for example, then and you can tell us more about the advanced stuff that we can do, showing that you have some specialist knowledge. That's usually only going to be good as long as you've done it, having done the basics extremely well. And then again, if you can highlight that there are other issues that might be relevant, mental capacity, consent, safeguarding, errors that might come up or be parallel to the scenario that you've been given. We try not to muddy the clinical scenarios too much with this because it comes up in the other scenarios. But, if you've got a delirious patient and the scenario is, assessing and managing a delirium, then these things are going to be relevant. And if you say these kind of things within the kind of medical management, then that's going to look good as well. It shows that you've been working on a ward and kind of the more advanced safety stuff. So let's take acute stroke, for example. So initial approach is going to be, someone comes in with weakness in their arm. So the initial approach, you're going to do the A, B, C, D, E, but you're going to pull out, are they maintaining their airway okay? Because they may have had a neurological event. What is the, B and C are going to be fairly straightforward, but you might be thinking of the blood pressure is relevant to a stroke. Then disability is going to be important. What's the blood sugar? What's the neurological status? And then importantly, within that, what's the onset time? So those are the key things you're going to need to show us what you're going to do, and not doing, unnecessary things like an ABG in a patient who's got SATs of 99% and has had a stroke, but you might want to do a VBG as part of the bloods. Then in terms of the history, we're going to want to, for the three, you're going to need to be able to take a history about when is the time of onset and have some idea about the thrombolysis indications and window, and know that you need to ring the stroke reg, get some brain imaging to exclude a hemorrhage. If you can do time of onset, urgent brain imaging or stroke call, depending on where you are, and then consider for thrombolysis or not, that's probably the basics of what you need to do. The people who are good are going to start thinking about, are they anticoagulated? What are the risk factors? Beyond that, once we've done the acute management, what are the causes of stroke? Well, we need to look for AF, we need to look for carotid stenosis, we need to think about vascular risk factors. And if none of those things, then we look for the more rare causes of stroke. So do they have a thrombophilia? Do they have an ASD or a these kind of things? People who can start listing those things off are going to look very good. So again, what we want you to know is we would expect you to be able to recognize, are they in the thrombolysis window, and how to activate the thrombolysis pathway. We would probably hope that the better people would have an idea of what the indications for thrombolysis would be and what the complications might be. And then, if you're getting a 4 or a 5, probably you're talking about thrombectomy. You're going to know roughly what to do with the antiplatelets. You'll be thinking about the cause of the stroke, that the swallow might be impaired, what their function is, how to modify risk factors, and how to rehab. And again, it's all about identifying the acutely unwell person, particularly with the airway, I guess, with stroke, if it's affecting the face and the airway. And then, to show your knowledge, you're going to be thinking beyond just the basic management and talking to us about, when will we anticoagulate versus antiplatelets? Are there any driving restrictions if the person is able to drive? Swallowing, I mentioned, occupation. And then again, investigating the cause. There is you should be aware of the stroke guidance that's available. There's some brand new stroke guidance that's come out just a few months ago. We would not expect you to know about that. Many of the consultants working in general medicine wouldn't know that there's been a brand new stroke guidance, but we would expect you to know that there is guidance available and that you can get that and know about the HASU system and how that might work. And then again, if you're telling us about the other things in the bottom there, then you're already well above the average person who is probably still doing the ABCD. Are they for thrombolysis or not? Because surprisingly, how difficult it is to get through these scenarios, and people, 6 minutes goes and we're still talking to them about whether they might be a candidate for thrombolysis, whereas someone who's scoring a 5 has just gone through that so systematically, showing us that they know exactly what they're doing, that we're talking to them about some of the more advanced stuff, and that's how you demonstrate your knowledge. So then you get 1 minute to hand over, and this is worth 5 marks. So practice doing this. You only get 1 minute. There's a very clear way to do it. There are several different structures that you can use. SBAR seems to be reasonable. Hello, I am the IMT doctor working on the acute medical unit at St Thomas's Hospital. We've admitted an 84-year-old lady who came in with right-sided weakness on a background of hypertension, diabetes, and a frailty score of 3, who is normally functionally independent. She has new left-sided weakness of onset 3 hours ago. She's got dense left hemiparesis, and I think that she has had an acute stroke. She's in AF on examination. Her new score is 0. I think she needs to be transferred urgently to the HASU for consideration of thrombolysis. I've called an ambulance and I'll be sending her there. Please would you know to expect the patient with a new score of 0, and please would you arrange urgent brain imaging and consider thrombolysis when she gets here. Really keep the details to what people need to know, and if you structure it like that, and you'll be at home in your interview, so write the key aspects down so that when you hand over, you can do that. I don't think there's any limit on taking notes. So ethical, governal, and professional is the last kind of area that's covered, and this is where people don't do very well, I think. Because people have a very superficial understanding of lots of these areas. So common things that come up, medical, these are all the same stuff that comes up in MRCP exams. Medical error, mental capacity, consent, safeguarding, professionalism, confidentiality, complaints, futility, among other things. So you need to be familiar with good medical practice and know the principles, as I said before. Duty of candour, people do not know what duty of candour is. They kind of go, oh, it means we need to be open and honest and apologise for our errors. That is true, but duty of candour process, there's duty of candour principle, which is being open and honest and apologising if a mistake's been made. And then there's duty of candour process, which is if a mistake has been made, the hospital and the healthcare team are duty bound to apologise. If there's been moderate harm, severe harm or death, then there is an obligation for the hospital to provide a verbal apology, followed by a written formal apology, and offer whoever the family or the patient are to be appraised of the outcome of the investigation for that, because if there's moderate, severe harm or death, there has to be an investigation, and then they are entitled to have the investigation results, and usually there's a time frame. So the really good people know that there's a duty to verbally apologise and then do a written apology, and then there's a whole system in place to make sure that that is followed. But we would expect you to know what the principle is, and then the good people will know that there's a process behind it, and that's what happens. Incident reporting, I'll talk to you about in a second. Mental capacity acts, you should know how to assess someone's capacity. You should know what a lasting power of attorney is for health and welfare or for property and finance, if possible. We obviously don't test in detail the legal aspects because this is an interview for an exam, and we know that some people come from different, but to have an awareness of these things is important, and about the court of protection and what the difference is between power of attorney and court protection and best interest decision making. You should know, hopefully any of you who've worked on a ward knows what a DOLS is. If somebody lacks capacity to make decisions about being in hospital, then they should have a DOLS, which is a framework designed to protect their liberty and make sure that we're not restricting their liberty. It also applies to care homes and other places. Have an awareness of advanced decisions to refuse treatment and advanced statements, as well as kind of just generalizing wishes, and then know about confidentiality and kind of PALS and complaints process. And be aware that if someone puts a complaint into PALS, I think everyone thinks that PALS reply to that. No, that comes directly to the consultant or the nurse who's in charge of the patient, and we have to investigate it. So I think lots of junior doctors have this idea that PALS will magically solve the complaint. No, I get an email 10 seconds after the person's been to PALS, and it says, "Dear Dr. Furmedge, this patient's just been in to complain. Here's the list of things. Please respond to them immediately." And it's about verbal de-escalation, formal responses, and just be an awareness that it's not just, patient complains and somebody rings up and says, "We're very sorry." There's an investigation process. So just going to talk you quickly through how to manage medical error. So this is a really poorly answered question because everyone thinks in a very, very small sphere of influence. So, the patient's been given an overdose of insulin. They've had to go to critical care for a glucose infusion, and they've come out that the patient has come to no harm, but there was harm caused because the patient had to go to critical care and has been in hospital for an extra 4 days. Tell us what happens next. People go, "Oh, well, there's been an error. I'll ensure patient safety." That's fine. The right thing to do is always ensure the patient safety. And then they'll go, and I'll do an incident report or a datix or whatever that it's called. What happens then? "Oh, well, the datix is investigated and the learning is shared." Okay, what happens then? The team will discuss between them about how they can do learning. Yeah, does anything else happen? Yeah, the team look and how we can share learning within the team. And nobody can get beyond that point. The good people will go, "Well, this is clearly a significant incident. We also need to apologise to the patient," and they can then explain about duty of candour. But you've got to realise that there's a much bigger response to an incident. And if you know about this, you'll look good. So we do the datix. Again, who gets to investigate that? The consultant looking after the patient or the nurse looking after the patient. There's no central team that do that for you. We will then work out whether it's a simple local problem, like the doctor's prescribed accidentally slightly over the dose of paracetamol, and actually there's no major learning. We go and talk to the doctor and say, "You did that mistake, reflect on it." If it's happened a few times, we might then share the learning, and then the trust will look at it. But actually what happens next is that everything's looked at on a trend review. If anything's moderate, severe, or significant harm, that triggers a bigger investigation that then comes outside of the department. And then the trust has to look at the trends and work out what's going on. It will be responsible for any root cause analyses or serious incident investigations for those things that cause moderate, severe, or difficult harm. Those things all get presented at trust level quality assurance panels and then are externally reported to the CQC, to NHS England, to the intermediate care boards, and they are looked at across. You need to have an idea what never events are and what that kind of triggers, which is this process. And then we report all of this nationally. So everyone gives a very circumspect answer about individual error, learning within the team and making sure it doesn't happen again. That's fine for small errors that happen occasionally, like a small prescribing error. But actually for big errors, there's a much bigger process, and it's important to just be aware of that. And you don't need to know the detail, but to just then say, I'm aware that then the trust is accountable. There are trend reviews. There'll be a quality team within the hospital looking at this kind of stuff, and significant events are reportable externally, and we may have to present what we've done to do those things. And then finally, professionalism is something that's coming up quite frequently. So a colleague does something dodgy, or breaches confidentiality, or does something on social media, or people are complaining that they're being rude. And it's all about how do you manage that colleague. And at your level, you're going to be an IMT trainee. You're not expected to manage this, but it's about, ensuring patient safety and thinking about any patient aspects that might have been broached and sorting those out. Making sure your colleague, you've explored a bit and you've got all the right information before you go running to somebody to give something wrong, and making sure that there's support in place for your colleague. The scenario will determine whether you should have a conversation with the colleague or somebody else, but it is difficult. Thinking about the wider team, are there any implications? And then obviously knowing what the pathways of escalation are. And you need to know about, freedom to speak up guardians. You need to know about that there's a clinical lead or a clinical director, that there's a medical director, there's a guardian of safe working, that there'll be, various routes, clinical and educational supervisors, that various routes that you can escalate things through to be able to do this. And this is a good place to draw in good medical practice. And what we're looking for is a measured approach in line with good medical practice, that doesn't throw your colleague under the bus, but maintains patient safety and makes sure that things are escalated in an appropriate but reasonable fashion, and that you are aware, of kind of what is an acceptable professional behaviour. So just be aware of those kind of things. And these are one of the more difficult ones to answer, I think, but actually aren't as complicated as people think. And then finally, we give you a mark on communication. So I'm not going to talk to you about this because I think most of it comes through, but this is about your communication in the interview with the interviewers. So do you do structured? Are you clear in what you say? Do you give things in a clear and logical manner? Are you nice and kind when you communicate? It's also around the communication that you might mention in the clinical scenario. So I noticed that the patient is acutely unwell. Once I've escalated, I'll make sure that I ring the relatives. What are you going to tell the relatives? Well, I'm going to tell them that, their mother is extremely unwell with pneumonia, and at the moment she looks very unwell. We're going to give her some treatment, but there is a chance she could deteriorate. But we're going to do X, Y, and Z. And I'd ask the family what their preferences are and whether the patient would have any preferences around her care. It's also around what information you're going to talk to people about in both the communication and in the clinical and the professional scenario. And your handover is going to be a key aspect of communication. Although that's marked separately, it will go in. So that's pretty much my tips. I think it is difficult just to tell you these things without you able to do it. So I would practice if you've got an interview coming up. And I'll have a look at some of the questions now and see if there's anything we can answer. But by all means, if there are any other.
Yes, thank you so much, Dr. Furmedge. That was a fantastic talk. There have been 3 questions so far. I'll quickly rattle through them if you're happy to. And if there are any other questions, folks, please do message them in the chat. We've got about 12 minutes or so in which we'll try and answer as many of them as possible. The first one that I would quite like you to just clarify, Dr. Furmedge, is somebody's asked about the start of the interview. Apparently the interviewers won't introduce themselves. Are you expected the moment the video goes live to start reeling off your 2-minute speech, or will there be some form of confirmation of identity and introductions made?
That's a good question. Yeah, we generally won't, to save you time, but there may be some slight variability. I think we'll probably say hello and please begin. If you're not sure what to do, you can just say, introduce yourself and say, are you happy for me to start my presentation? I think from memory, from last year, there's an admin person who says, and I think most of the interviewers will say, please begin. But if you're not sure, it's fine to just say, you're happy for me to start the presentation. But I think there'll be a prompt from memory.
Fantastic, thank you. The second question was about whether or not we can talk about ongoing projects during our interview. Somebody asking, can we only talk about things that have been completed, disseminated, considered achievements as they might be scored on your points allocation?
No, absolutely. If it's relevant to the interview and you're involved in something that's ongoing, tell us about it, because you may not have put it in your portfolio, so we may not have seen it. So if there's something additional that you think is relevant, then definitely happy to hear about it. And so you might need to signpost us to that if you want to flag it.
Fantastic, thank you. And the third question that appeared during the talk itself was how the clinical scenario would run. Are we expected to talk through everything in one go, almost like the presentation at the start, or would it be a much more dialogue focused, I assess for this, and then the examiner gives us a...
Everyone does it slightly differently. I think we usually start by talking something like, tell us your approach to this clinical scenario. How would you approach this? And therefore that gives you a chance to, as I was saying, do whatever you think. So if you give us a 30-second very rapid ABCD and you stop there, then we'll start asking you questions. The interviewers get some prompts of questions that are what do you think the differential diagnosis might be? How might you investigate the patient further? What would your management be? So some people will have raced through and given us a lot of that already because they'll have tried to get everything into their initial thing. If you're going down a line we don't want you to go, we'll probably stop you. But it's very individually varied. We try and take you through the whole scenario so that we know that we test everyone on roughly the same thing. some people will give us a lot of that in the introduction. Other people will need to take them through it in a systematic way. It doesn't really matter which. It's all about just being systematic and doing it.
Grand, thank you. And going back to talking about our achievements in the first section of the interview, there's a question about finding the right balance of talking about the achievements and demonstrating appropriate reflection. I suppose when time is limited, how do we find that balance between trying to talk about everything that we've done and showing appropriate reflection on each of those?
Yeah, I think it's always a challenge. So I would always have the one in each section that you want to highlight ready to go. But it's fine to, the way to do it is to signpost and say things like, I have published 5 papers in the last 5 years on a number of topics, including, I don't know, delirium and, falls. The one and then talk. But you can highlight that you've done more than one thing, and then usually go on to talk about, or if they're related, you can. I think you just have to signpost us so that we're aware if you want us to know something that we haven't seen. But in theory, we've looked at your portfolio, so we should have seen the breadth of stuff that you do. And the conversations go along the lines of, oh my God, this person's amazing. They've done so much stuff. Look at their portfolio. They've got a better CV than me. And, generally the interviewers spend some time looking through. So if it's in there, we've often seen it, but it is a good idea to highlight those.
And thank you. And on the topic of engaging with the clinical scenario, a couple of questions about, I suppose, the specifics of how it would proceed. Some people asking, do we talk through the specifics of what we'd want included in our A to E? For example, in respiratory exam, do we say we would listen to the lungs, look for chest expansion in a much more, I suppose, medical school, OSCE style station? And linked to that is, would it be reasonable to start by asking about new score and a general inspection of the patient and saying that you could feasibly take a history first if you think they're not acutely unwell?
Yes, I think so. In terms of I think it's really tedious for us to have to listen to, I would auscultate the chest and listen for chest expansion. I think there are ways of showing us that you know how to do the ABCD assessment by doing it in a succinct way, but highlighting the relevant things. So, for example, in asthma, B is going to be really important. So you're going to say, and B, I'm going to look at the respiratory rate. I'm going to examine the chest, particularly listening for any wheeze or reduced air entry, and going to want to know the oxygen saturations, and then consider a chest X-ray and an ABG. And in that short sentence, you've told us all the key things that you want to do probably for an asthmatic without telling us each individual tiny step that you want to take. So that's what I mean about really keeping it concise and picking out the things that are relevant to the scenario. There was a second bit to that question as well, I think.
Yes, it was. Is it a reasonable approach to begin by asking for a more general overview, news score, how the patient looks, so that you can decide whether or not you can afford to take a focused history before beginning your assessment?
The examiners probably aren't going to give you any more information apart from what they've been allowed. So, for example, like I said, we might be told to give you a simple investigation result or what have you. But if you say, does the patient look okay? We can't give you that. So. I think, it's fine to come in and say, obviously, I'm going to do, if it's that, it's an old lady who's fallen over and the scenario very much is not that they're, in an emergency, you come in and say, obviously, my initial approach is going to be A, B, C, D, E to make sure that, the emergency stuff is sorted. However, what's going to be important here is taking a full history, asking about, what's happened before the fall and etc., doing a full physical examination, looking for, any cause for the fall and any trauma. And there's no right or wrong way to do it, as long as you signpost that you would do things in the right way. And I think, although I hate it when everyone comes in and just says A, B, C, D, E, I think the scenarios are a bit different and you have to put it in there somewhere. But if it's really not a really acute scenario, I think it's fine to just keep that bit focused and then explore more the other bit.
Grand. Thank you very much. A couple of questions, I suppose, about paperwork and admin. First question, are we allowed to have a pen and paper to make notes during the interview?
I think so, but I'm not 100% sure. When you log in, the admin people will tell you, but I can't see any reason why you can't. But I can't give you 100%.
And I think it's worth checking the website for clarification. To the best of my knowledge, you are, on the condition that you dispose of all notes immediately after the interview. And linked to, I suppose, admin is a question about, do we need to have any evidence to hand for the things that we've mentioned in our application form? I suppose QI, P forms, any certificates.
No, because you should have put all of that in your portfolio for the evidence verification anyway. And that there's already been independent portfolio verification. So a selection have been through the audit process. So no, you should just be able to. It would be very unusual. I mean, it's not impossible for somebody to say, could you provide us with evidence after? But I don't think that's likely to happen.
I see. Thank you very much. That, to the best of my knowledge, is all the questions that have currently appeared on the chat, and all have been answered. We've got 4 more minutes. Are there any other questions? We'll take a couple of minutes, just wait to see if any more come through on the chat.
Someone's just asked, we will be given 3 minutes. Yes, it's all very strictly run by an administrator, so you should be given your 3 minutes to read the scenario, and at that point I think you can take notes if you want to.
Thank you. Give it 1 more minute. Are there any other questions?
The 1 minute handover, yeah, you'll be told, you've got 1 minute now, please could you hand over your patient to the ITU registrar or whoever it might be. So again, it's very strictly timed because we've got to keep the day moving and give everyone the same time. So, if you're still on S in 1 minute, you're going to be moved on. Cool. That's probably it, isn't it?
I think so. Lots of thank you messages. Yes, I'd like to reiterate our thanks on behalf of Mind the Bleep, Dr. Furmedge. That was fantastic talk. Yeah. Thank you so much, especially for myself, given I've got my interview coming up next week.
Okay.
We shall end things there. Just a bit of housekeeping. This speech has been recorded. We will aim to get this uploaded onto most likely YouTube in the coming days. Don't hesitate to contact Mind the Bleep on the website if you have any further questions about this session. Thank you so much again to Dr. Furmedge. We will end it there.
Good luck to anyone who's got an interview coming up.
Thank you so much. Now I'll end it.